Okay, hi guys. How are you all? I hope you all are doing well. With the rising COVID cases now, please stay safe and stay inside your homes as far as possible. Get vaccinated, it is important. I am so sorry that I was really busy in the last month and I couldn't post any video. I think posted just one video, and after that I couldn't post anything in the entire last month, although I try to post one video every 15 days. I got the opportunity to attend the National Hematology Conference held in BHU Varanasi under Dr. Vijay Tilak sir's able guidance, and it was a wonderful academic feast. And I met a couple of you who are a part of our family, our YouTube family over there. So it was Priyanka that I met, and I was really very happy to interact with you all. To get to know your feedback is very, very important. And as I always say, and you were really sweet to me, really nice to me. So thank you so much. I also made a couple of all of you I met there. I now we've become friends. So and we also added Pragya to our family, who's an MBBS from the college where I'm working as an assistant professor now, and she's doing her JR-ship. She's a JR1 in BHU in Department of Pathology. And this conference had really eminent speakers like Tejinder Singh sir and HP PATI sir, then Dr. Seema Sharma ma'am from SGPGI, and faculty from Tata Banaras, as well as really eminent people um, who are visiting, and teaching us. All the seven speakers, I think, and all of them greats in their own field, and I learned a lot. I'm still a student. I got to interact with some of you who are there, so we all are now a closer family. And so today, whatever I will be discussing, some of that, whatever summary of those very, very good academic lectures that we learned from, I'm going to be using today also, and I'll convey whatever I learned from those lectures to you. uh, of course, there are just two topics that I'll be covering today, so not everything will be conveyed, but I'll try my best to convey whatever I've learned relevant to these topics. And then, as we progress and as our topics, change, and whatever I've learned, I'll try to, I always recommend everyone to attend this hematology conference, which is held annually in Varanasi. I will share the link next time I get it from Sir or from any other source itself, because it's kind of an update of all the recent things that are going on in hematology. So I thought I'll take 2-3 minutes to first tell you about the Varanasi Hematology Association conference, which always organizes and brilliantly executes them with such good speakers from, I think, from JIPMER to Delhi. Sir covers all the good speakers, and sir, invites everyone who can, really teach us a lot in hematology. So moving ahead, let us move now ahead, and I'll try and be more consistent with uploading my lectures. So we'll be had discussed about chronic myeloid leukemia. Today we'll be discussing in very brief about chronic neutrophilic leukemias and polycythemia vera. Again, these form a spectrum of myeloproliferative neoplasms. Now, I have, before I start with what chronic neutrophilic leukemia is, everything in hematology is done as per set definition, and that set definition is given by the WHO. So that is why we need to be updated every year about whatever WHO is changing, and then only can we fit something in a criteria and diagnose. Now, the thing is ki, before I go ahead with chronic neutrophilic leukemia per se, I would also like to tell you, and have told you before, that CML in itself presents in three morphological forms. It can be a classical CML, it can be a granulocytic CML, it can be an atypical CML, and the differentiation between these three is done by the percentage of blasts, the percentage of neutrophils and and monocytes, and the percentage of mid-series cells, as well as ATPR in the myeloid lineage, which is being seen on the slide. So we need to be careful to not diagnose. So there has to be an overlap when you are diagnosing a CGL or a CNL. So you need to be very very precise. वो जो criteria दिए है, it is given in Tejinder Singh's book. It is given in my book also. Of course, my book is not of. I'm not comparing mine with Sir's book. Sir's book is like the text, but if you want something in brief and short, you can go for my book also. It is there in Flipkart, it is there on Amazon, and it is there on Ahuja book publication website. So the thing is that you need to remember those. ऐसे ही याद करो, like just remember कहाँ blast percentage different है, या किस वाले में इन तीनों में ATPR मिला, लेकिन atypical CML you get ATPR and dysplasia to a large extent. CML में CGL में नहीं मिलेगा. CGL में मिड सीरीज बहुत ज्यादा प्रोलिफरेट करती है, क्लासिकल CML में नहीं मिलेगा. तो ब्लास्ट 2% 2 to 10% ऐसे करके ना कट ऑफ दिया है. You just remember that cutoff, and then you can those only specific points to differentiate between the three categories. Having said that, I have seen a CML case when I was working in a pediatric setup where it presented with marked neutrophilia and count approximately 1 lakh. And it was very very, and we were confused to whether to call it CNL, CML, what. I don't, we were not very sure about it. And then of course the molecular was the case came out to be as CML. Pardon me, I'm very tired. So the case came out to be as CML, but it presented with marked neutrophilia. Rather than the mid-series cells, there were more. So what I want to tell you by this example is that the lines are not very well defined when you start categorizing CML into its various forms, or even into CNL. It is more well defined as a CML, MPV, ET, PMF, rather than a CML, atypical, CGL, and then a CNL. So this is what I wanted to tell you by this example. So you need to, in the end, rely on molecular studies also. So what is CNL? It is a myeloproliferative neoplasm, as I've said, with an immense neutrophilia. And the bone marrow is hypercellular, you will get hepatosplenomegaly. The peripheral blood count in CNL is more than 25 into 10^9. And what is more important is you will get segmented neutrophils and band cells more than 80%. All right. But this is, I have seen a case which is an aberration to this definition. Bone marrow is hypercellular, there will be neutrophilic granulocytes and normal neutrophils. Myeloblasts will be less than 5%. It won't meet WHO criteria for any other lesion, including CML. No PDGFRA, B, FGFR1, PCM1 JAK mutation. CSF3R mutation is present or persistent neutrophilia for greater than 3 months with no identifiable cause, including absence of plasma cell neoplasms. This is the most important point over here, that when something which is presenting with a persistent high count, persistent neutrophil, no other mutation you are getting, and you get this CSF3R mutation, then you label it as CNL. And the prognosis is between 6 months to 20 years. So CNL, I have not put a lot of, it is nothing, it's neutrophils, mature neutrophils in the peripheral smear to a count of say 1 lakh, 2 lakh, you will get that. So that is why I have not put an image. What I wanted to stress by writing CNL is, if you get high counts and you are getting just neutrophilia, don't label something directly as CNL. Go for a molecular. Either you get a CSF3R and rest all are negative, then you can yes label, or if you've not gone for a molecular, you're treating the patient and persistently for 3 months you're getting similar picture, no change in the picture, then you can go for then you can label something as a CNL. Now coming to polycythemia vera. Now in the conference that we went, a lot of MPNs were discussed and we were shown slides of all types of MPNs. So I will in the end show you what was very very specific takeaway point in diagnosing these various MPNs. Today I'm only taking polycythemia vera, but that one image I'm going to show you in the end and discuss, okay? So polycythemia vera is another MPN with increased RBC mass, slightly more predominant in males with a median age of 60. I have seen polycythemia vera in a 22-year-old boy also. So the median age is then WHO, but it can occur in young. Clinically, it is important to differentiate primary versus secondary. Why? Because cause of secondary polycythemia varies. It can be a tumor in your kidney. It can be you not adjusting to height or depth. It can be you are a persistent smoker. You have a cancer somewhere and it is paraneoplastic to that. So secondary polycythemia, or you have a renal disease. So secondary polycythemia needs to be ruled out because primary is a genetic condition, primary is a hereditary. You have some mutation and that is why you have a primary condition, and then the treatment for primary is straightforward. जो दवाइयाँ देनी है वो straightforward मिलेंगी, phlebotomy होगी, whatever. Secondary, the cause needs to be treated. So when a child comes to me or when an adult comes to me and the CBC shows a hemoglobin above the cutoff criteria, 16.5 for I think female and 16.5 for male and 16 for female of hemoglobin, I don't directly label it as a PV. I will go ahead, get all the other investigations done. First, repeat the CBC after a week. If the same results are coming, I'll take history, rule out relevant history like are you pregnant, are you on some, are you smoker, are you on medication, are you living on the heights, or what is your profession, or is someone a scuba? Obviously, you won't get a scuba driver here in UP where we work, but you might get it where you are near the coastal areas. And then is there any renal mass? I'll get an RFT, LFT, other investigations done, an LDH. After ruling out everything, will I label something a polycythemia vera? And then the most important investigation is serum EPO level and JAK2 mutation. Subnormal serum EPO level and JAK2 mutation positive. Having said that, again, I will say every time I say having said that. Having said that, there are reported cases which are JAK2 negative, yet reported as polycythemia vera, responding to the treatment of polycythemia vera. Again, I'm giving you this example from practical point of view so that you know that hematology keeps changing, criteria will keep changing, so you need to be updated if you love hematology, if you want to be a hematopathologist. Okay. So when you have no hypoxia of any sort, no stimulus, okay, and then there's an independent EPO stimulation, then and of course the sites which get stimulated by EPO is erythropoietin, which produces more RBCs, is bone marrow, spleen, liver. A lot of RBCs will be produced. The patient will come to you with symptoms of hyperviscosity, that is headache, blurring of vision, thrombosis, tingling, numbness, because excessive RBCs are clogging the blood vessels and producing ischemic symptoms. And that ischemia is because RBC mass body में बढ़ गया है. Imagine your vessels as a sewage pipe, and then imagine excess of hard sewage in the vessel instead of flowing water. तो प्लाज्मा के कंपैरिजन में जब आरबीसी बढ़ जाएगा तो वो जो फ्री फ्लो ऑफ ब्लड होता है वो स्लगिश हो जाएगा, एंड व्हेन दैट बिकम्स स्लगिश देन इट स्टार्ट्स स्टैसिस अकर्स, एंड स्टैसिस के बाद ये सारे फीचर्स आने लगते हैं. एरिथ्रोमलाल्जिया, फ्लशिंग, रेड एक्सट्रीमिटीज, रेड फेस, दैट इज एरिथ्रोमलाल्जिया. ओके. So the 2008 WHO criteria was, I have put it on purpose, a hemoglobin of greater than 18.5 in men and 16.5 in women with presence of JAK2 or other functionally similar such as JAK2 exon 12 mutations. However, the major criteria in 16 has become 16.5 for males and 16 for females, or hematocrit 49% in men and 48% in women, rather than it being 18.5 and 16.5. So now instead of 18, the hemoglobin cutoff has been dropped to 16.5 for men and 16 for men and women, and a hematocrit of 49 and 48. Bone marrow biopsy showing hypercellularity for with age, that is panmyelosis, including prominent erythroid granulocytic megakaryocytic proliferation with pleomorphic to mature megakaryocytes. Matlab there will be different size. And of course presence of JAK2 mutation. Minor criteria remains the same. Initially, the bone marrow was a minor criteria. Now it has become a major criteria. Okay, and then subnormal serum EPO level remains. We don't anymore put endogenous erythroid in vitro. We don't do that. Okay, and then criteria required for diagnosis is all three major or the first two major and one minor. Means hemoglobin तो बढ़ा ही होना ही चाहिए. Bone marrow में changes हैं. EPO subnormal है. You can label it. Otherwise, you go for all the three: bone marrow, JAK2 mutation, and hemoglobin. We normally go for all the four actually. Okay, so this I've already discussed with you. Okay, this thing, sustained increase of greater than 2 gram per DL from baseline of hemoglobin, ये हट गया है. This is simple. 16.5 for men, 16 for women, and hematocrit 49 and 48. ठीक है. So diagnose, and then you all should know that polycythemia vera has phases. ठीक है. Pre-polycythemic, polycythemic, and then a spent out polycythemic phase or a post-polycythemia. Since these all are a spectrum of MPN, fibrosis sets in invariably after a long term of the disease. So in the long time, the polycythemia vera starts mimicking a myelofibrosis. Okay, so such cases have a previous report of PV, might not have. Bone marrow grading is there, fibrosis occurs, anemia is there, you'll get leukoerythroblastic picture, you'll get a newly palpable spleen, weight loss, unexplained more than 10% at 6 months, B symptoms, that is night sweats, fever greater than 37.5, spleen more than 5 centimeters, and for such cases prognosis is poor. ठीक है, up to 10 years survival रहता है, might progress to MDS. Again, molecular investigation in such cases will be the most important thing to do. But you should know that sometimes a PV can become a PMF, can mimic a PMF because of a lot of fibrosis. Okay. So this is an image of polycythemia vera where you see panmyelosis. Supposing this ऐसा marrow होगा 60 years के बंदे का. Excessively, and there will be a lot of erythroid cells. यहाँ पे भी दिख रहे हो कितने सारे erythroid हैं. Megs will be together, might be scattered, might be together. जैसे यहाँ पे scattered है, ठीक है, ये एक है, एक ये है, एक ये. It might be together in loose clusters. What loose clusters mean is you'll get these other cells in between the megs, and they'll be morphologically normal. Might have some a little variation, some a little hypolobated, some normal, but mostly mature. Why I have shown you this is because I wanted to discuss this in short. Then I'll keep coming back to the slide every time I take a topic. In PMS, the megs have a tight cluster like this with no other lineage cells in between and might have dysplastic features, very hyperlobation, very hyperchromatic, intense looking megs. This is not very high. Maybe this one is a little hyperchromatic. Maybe this one is a little hyperchromatic. This is all right, but the cluster is very tight. In essential thrombocythemia, in all these two, you might get a panmyelosis. In what stage it is, we don't know. You will get very, very giant and bizarre megs with balloon-like cytoplasm. Rest everything will be normal. In CML, you will get a dwarf meg. Where is the CML? Yeah. In CML, you are going to get dwarf megs. As shown you in the last lecture, you can go ahead and see. So, looking at the megs, you can make a diagnosis कि ये PMF रहा होगा, PV की CML की ET. And of course, in MDS, you get micromeg and absence of megs. So, megs are very important in diagnosing MP and MDS in marrow. I'll keep going over it every time. I'll keep repeating it so that this sticks to your skull once we finish MPN. But this is an important item which you need to understand. So I think we'll end today. I had just taken small two topics. This is my book. It is available. All this, whatever I'm discussing, is available in this book. Not very expensive. It is just 188 rupees. Please go ahead, buy it, share it with your friends. Please help me out. I am just a budding writer and I love teaching. So I thought that for whoever loves hematology, a small handbook is very, very important. And I would always love your reviews about the book. So I hope I'll be able to post more consistently from now on. And I'll see you in the next lecture soon. Till then, Keep smiling and keep studying. Bye bye.